afternoon, everyone. Thank you for being a part of this session. I wanted to introduce our panel, and then we'll hear from each of them. And then, as Matt said, we'll leave some time for questions. As you are listening to our speakers today, feel free to write down questions on the cards that you have in your red bags. There should be cards and pens in your bags to do that, and then we'll come around and collect them. So I wanted to introduce our speakers this afternoon. Dr. Kimiko Demoto-Riley is a neurologist. She completed her residency and fellowship at Brigham and Women's Hospital and Massachusetts General Hospital, and then served as a clinical and research staff neurologist at the MGH Frontal Temporal Dementia Unit. She is currently involved as a neurologist now at the University of Washington and has been there since 2014. And she sees patients at the Brain and Memory Wellness Clinic. She also has a specific interest in researching aspects of FTD. So we'll be hearing from her first this morning. Then our next panelist is Maura Silverman. Maura is a speech and language pathologist and has always been passionate about helping others. In her role as the executive director of the Triangle Aphasia Project Unlimited, Maura is able to help those with communication who have helped those who have been robbed by stroke or brain injury. She created this organization 16 years ago to allow individuals to receive programming for as long as they need it. And then joining us to speak about the perspective of someone living with a diagnosis, we have the very Reverend Tracey Lind. She is a retired Episcopal priest and city planner whose career has included work for social and environmental justice, interfaith relations, sustainable urban development, arts and culture, and progressive theology. Most recently, her ministry has extended to include the spiritual insights and lessons that she has gained from a life complicated by dementia. She's also a member of the AFTD think tank and will be speaking with us today about living with FTD. And then Emily Ingalls will also be joining us. Emily spent more than 20 years in commercial real estate and project management. She was an early proponent of sustainable buildings. She is now the chief logistics officer at Trinity Cathedral in Cleveland and is that not?
Of our life. I'm a logistics officer of our life.
Logistics. She's also an avid gardener and beginning birder and aspiring cook. So again, as our panelists are speaking today, please feel free to write down your questions so that they can be included in our panel discussion later on. So we'll begin with Dr. Demoto-Riley.
Great, thank you. Can you guys all hear me okay? Great. So as you've heard, I am not Dr. Sajjadi. Unfortunately, he had a family emergency, but his email is at the end of this set of slides, and you're welcome to email him with questions if you have any specifically for him. But I'll be providing his slides for you. So first, I'll be talking about early diagnosis and why it's so important for us to make an accurate diagnosis as soon as possible. Review the different subtypes of primary progressive aphasia, talk about treatment options, and also research. So primary progressive aphasia has a very slow onset, so usually you can't pinpoint a day, a week, or even a month when the symptoms began. And gradually over time, there is progressive impairment of language abilities. And this is different from stroke aphasia, because with a stroke, typically you can say there was even a moment when everything changed, and then gradually there is some improvement over time. Unfortunately, with primary progressive aphasia, we need to plan for progressive decline in language abilities. And this is because these symptoms are due to degeneration or slowly progressive loss of brain cells in the language areas of the brain. This was first described back in 1893, but then there was almost 100 years went by before the research community and physicians again became interested in this condition. And it was in 1980 when Dr. Marcel Mesulam at Northwestern coined the term primary progressive aphasia. This is an underdiagnosed condition, and many of you may have experienced this already, that sometimes it's hard to figure out what is going on. PPA is as common as behavioral variant FTD, and it affects both males and females equally. And most of the time, PPA is not hereditary, but a few people do have one of those genetic changes that's causing their language changes. And PPA can also affect people who are older. It's not just people who are younger, as we tend to see with behavioral variant FTD. There are lots of diagnostic challenges. As we already talked about, things can gradually creep up. And often in the beginnings, there is a sense, the person who's experiencing these symptoms says, my symptoms don't seem to be part of normal aging. I feel like something else is going on with me. But unfortunately, sometimes things are dismissed as, oh, you're going through menopause, or oh, this is just depression. We also don't have very specific tools for primary progressive aphasia, and it can be challenging both to do accurate evaluations in the very early stages of the disease and also in the very late stages. So we need to have better tools. You were hearing about biomarkers this morning, and we don't have biomarkers specific for primary progressive aphasia. And then again, you heard about the heterogeneity. So over time, not only are these different diseases, but the symptoms change over time. And we'll talk about this a little bit, and because over time it may not just be language that's involved. There may also be movement changes, for example, or behavioral changes. Is this better or worse? Better? Okay. I'll try not to pop too much. And the reason why we want to diagnose people as early as possible to make sure that we have an accurate diagnosis is, one, if we do eventually have disease-modifying therapies, that would be to clear out those protein tangles. They would be most effective early before there's a large accumulation of the protein tangles. However, we also want to make sure that we're providing appropriate therapies. And again, that accurate diagnosis is helpful as early as possible so we can make sure people are on the appropriate plan. It's also helpful to understand what is going on and to decrease that frustration. Also to make sure that individuals and those around them are safe, especially as the language challenges mount. And especially early on, we want to make sure that everybody has a voice, has a say in how to plan for the future. And so that is why we want to help make this diagnosis as soon as possible. So for the different subtypes of primary progressive aphasia, there are different flavors. So the symptoms begin differently. And then, as I was mentioning, over time, if we think about one specific diagnosis, we might expect a different trajectory. So it can affect, for example, what we would project potentially for life expectancy, and also whether we would be on the lookout, for example, for motor changes such as Parkinsonism. Also, thinking about the different flavors of PPA can have different implications on future care needs, independence, and also, as you'll be hearing from the other panelists, how we think about appropriate interventions. And another piece of it is that depending on the type of PPA someone has, the underlying protein tangles there often is a fairly good mapping onto different protein tangles, which I will talk about in a moment. So again, we talked about how we think about definitely symptomatic treatment no matter what, but in the future we think it's going to be important also to think about disease-modifying therapy might be different for somebody with underlying TDP-43 pathology versus underlying tau pathology, for example. So these are the different subtypes. There's a semantic variant of primary progressive aphasia. There's non-fluent or agrammatic variant, and unfortunately the two are kind of lumped together. Sometimes in the beginning the symptoms can actually sound quite different. And then there's the logopenic variant. And there are two other disease profiles mentioned here, progressive supranuclear palsy and cortical basal degeneration, because these are symptoms that we look out for as time goes on, although these are not traditionally thought of as PPA. The PPA subtypes are semantic variant, non-fluent variant, and logopenic variant. For semantic variant, you can see on this picture here, this is a picture of a brain, and this is the temporal lobe. And usually it's the left temporal lobe. Each part of our brain and each hemisphere of our brain has different specialization. And in some ways you can think of the temporal lobe, and especially the left temporal lobe, as being where the brain's dictionary is. And so people who have degeneration of the left temporal lobe often have semantic variant primary progressive aphasia. So speech remains very fluent, grammar remains intact, especially in the beginning stages, but there's a breakdown of knowledge. And so this is knowledge of word meaning, and then sometimes also what objects are. And usually it starts out with losing this anomia. It's hard to come up with words, specific words. You might be able to think of the word bird, but not the specific word pelican. And over time, this becomes more problematic, but there may also be some behavioral issues that arise. In comparison, the non-fluent variant, or non-fluent agrammatic, is affecting, you can see here, the left frontal lobe. And so speech is not fluent. Instead, it's very effortful. And so there may be single words that come out, and there may be grammatical mistakes as well. And the grammatical mistakes can also be in understanding grammar. There are sound errors that occur due to what's called apraxia of speech, and this is how our brain coordinates the tongue and mouth movements in order to produce accurate speech. Over time, there can be movement changes that occur, and the person begins to develop features of progressive supranuclear palsy or cortical basal syndrome. So there can be more Parkinsonism, and it can be harder to move. There can be falls, and there can be eye movement challenges. The last one, logopenic variant, primary progressive aphasia. The word logopenic means few words. So when the person is speaking, there's often these pauses to try to come up with a word. And there are also sound errors when a word is spoken. When you go through testing to try to figure out what type of progressive aphasia this is, with repetition, if you give a long list of words as in a sentence, that can be difficult. It's too much, too many sounds to reproduce accurately. And again, this is involving the left side of the brain typically, and is a bit further back from that front part of the temporal lobe. Involves more of the rear part of the temporal lobe and the parietal lobe. Logopenic variant primary progressive aphasia, though, is not typically due to one of the FTLD pathologies. It's most typically due to Alzheimer's disease. So some purists may say, well, this is actually language variant Alzheimer's. It's not frontotemporal lobar degeneration. And again, this will likely become quite important to disambiguate because treatment for underlying Alzheimer's disease is likely to be different than treatment for underlying FTD pathology. In terms of drugs, and you heard a bit from Dr. Mendez this morning, that we actually in FTD think outside the box. We don't like to constrain ourselves to drugs, and in many ways we prefer to avoid giving drugs at this point in time. There is no curative treatment. Unfortunately, we cannot stop this progression of symptoms, and we can't reverse what is going on, but we definitely want and need to treat the symptoms. And so in addition to treating language symptoms, we also think about treating the behavioral issues that can occur. Sometimes, unfortunately, depression can be a major concern because it can be very isolating to have difficulty communicating as rapidly as we tend to do day to day. Sometimes sleep can be an issue. And then I was mentioning some of the Parkinsonism, some of those movement changes that can go on. And that's when we might think, for example, about physical therapy. So other interventions involve exercise. Exercise is very important for the brain, and so we want to make sure that we're selecting exercises that are safe and that can be used over time. Eating healthy diets is also important. We think, for example, about the Mediterranean diet, so green leafy vegetables, whole grains, fish. For speech and language therapy, you'll hear a lot from my colleagues, but we do think differently about appropriate treatments early in the disease and later, but a lot of it is also to provide each person and the people they communicate with effective strategies that can serve them well for the long term. There are some thoughts that non-invasive brain stimulation may also be a non-drug way to treat PPA, but this is very much in the research world right now, but stay tuned. You've heard some challenges in the research in that these are a few different diseases that are all being lumped into one category, but still sometimes we can use that to our advantage to take advantage of many different types of treatment. We do think about the different underlying protein tangles or abnormal proteins, the pathology, and then over time we're thinking about different targeted treatments. There is a relative lack of clinical trials, but there are research opportunities, but this is also why we are hoping that all of you can help us in this battle. So this is Dr. Sajjadi's email if you have specific questions for him, and I will pass it on to the next.
Okay, can everybody hear me? Okay, now I know the recording can too. So as I was introduced, I am very blessed to have left my really good paying job to start a nonprofit organization 16 years ago called the Triangle Aphasia Project. And one of the things about TAP is we serve 3 different populations. And I kind of just want to see who's in the room so that we can personalize this a little bit more. But we say that there are people who have aphasia. So if you have aphasia, raise your hand. And number 2, we serve people who love someone with aphasia. And then we also serve people who serve people with aphasia in one capacity or another. Wow, that's great. So we have all of them. Some of our roles overlap, right? I have those, because I love someone with aphasia and I serve somebody with aphasia. All right. So we hear a lot of things, not just from individuals with aphasias and their families, but also we hear these things from professionals about, well, it's progressive. Insurance companies are the first one. Again, another reason why I quit my really good paying job to start a nonprofit was I was being told by the insurance companies how long I could see somebody with aphasia. This is a lot of the things we hear. It's going to get worse. Why do this? What can I work on? How can I document progress if somebody is going to get worse? I would say that there's some thoughts behind some of those things, and you can see that those are things like, you know what, it's exhausting. It's really hard. I'm always playing middleman when somebody is communicating with the person I love. Or when I have aphasia, people look at me like I don't know what I want to say, and I do know what I want to say. I just have trouble getting it out. So this is an opportunity to take and look at really what communication is. And it goes way beyond just the kind of interaction and transaction that we think of with communication. So it is not just about me expressing that, I have a stomachache or that I have a headache. It's your thoughts, it's your feelings, it's your ideas, and that's the stuff that we need to really focus on. So the better definition of communication is really about purposeful engagement, being able to provide connections with people, and not just in a verbal way, but oftentimes in a nonverbal way. I love this quote that I found when I was creating this PowerPoint about communication. It connects strangers, may lead to finding love, and even prevents war in some cases. It's pretty powerful. So I'm hoping this works. Is anyone familiar with this video series? This was created by a young man who set up, and I'm hoping this works, this is the son talking to his mom, who is named Molly.
So you weren't sure who my dad was. You know who my mom is? Huh? What now? Said you weren't sure who my dad was. You know who my mom is? You know who my mother is?
My volume isn't working here, sorry.
You don't know who my mom is? All right, I'll let you think about it. I'll let you think about it. Who my mom is? I'm Joey. Who's my mom? I don't know, Joey. Okay.
Okay, the next part of that is that Molly's movement, and I can't for some reason fast forward or make it louder, but has Joey in his car broke down in tears that his mother can't access the information to have an exchange with him. And I started thinking about communication, and I thought, really, why is he so upset? Is he upset that he had to order her Frosty? You know, is he upset that he had to keep repeating the question? The reason that we get frustrated with the lack of communication is not because of the transactional aspects of communication. It's about that we lose connections. I don't know how many people out of my over 200 clients that I see with aphasia say to me, my friends are gone. And it isn't just in when they lose speech from primary progressive aphasia, but even when they've had a stroke, because you get all this initial help and then people go back to their lives. So clearly, Joey was not concerned with that. What he really misses is about the connection and what we need to be able to do to help individuals. So I'm going to speak from a perspective of both a person who loves somebody with aphasia and two also providers, in that some things that we absolutely have to do is we have to spend less time administering a bunch of tests and then saying, come back in 6 months and we'll see how you're doing on those tests, and spend more time on getting to know who the person is. And I'm going to show you some ways to do that, but I'm also going to show you some ways to advocate that that is being done. One thing that I do is, as a provider, as a speech pathologist, the very first thing, before any Western aphasia battery or Boston Diagnostic aphasia exam comes out, is to find out who the person is. How did they spend their time? Whether that they had a stroke or they have a brain tumor or they have primary progressive aphasia, who is the essence of this person? How do they, what's their story? What's their narrative? And I do that with things as simple as this circle that's in the middle of saying, show me what a pie of your day looks like, you know, before you had primary progressive aphasia. What did your day look like? How did you spend it? It tells you a lot about the values of the person and how you can work on things with them. And then you look at helping maintain their independence and their participation. So focus on the things that they are able to do, and make it strength-based. So when you're talking to somebody and you're finding out about that person, what do they love doing? Well, I love making scrapbooks, or I saw you nodding with birds. If you love birds and you love bird watching, that's your fodder for language stimulation and engagement. And what those things do is continue to offer the person purpose. And I thought that was great how Martha kept talking about purpose in some of our talks this morning. And I use this phrase that my mother always said, don't throw away the baby away with the bathwater, which I think is an awful saying, by the way. It sounds terrible. But what it means is just because somebody can't do an entire task by themselves, it doesn't mean we just toss that task away. We wouldn't do that if somebody had a little trouble walking, right? someone has a little trouble walking, a physical therapist will say, what's the least level of support they need to be able to walk safely? We need to do the same thing with communication. This is a book that's actually written for stroke victims, but I absolutely love it because it's so practical. And it talks about tasks being either unimportant, but reinforcing and positive, interesting, and that when we work with individuals who have communication challenges as a provider, let's throw away the workbooks. Let's not be writing, you know, the ABCs. I haven't written the ABCs since, you know, kindergarten. Let's write things that are important to the person. As I said, a person that has some movement disorder is not going to be given a wheelchair if all they need is a walker. But moreover, they're going to make sure that walker is available to them. So I saw a lot of people talking this morning about the cards. That's so essential, important to be able to share that I have aphasia. These are some of the things that you can do to help. But if you don't have a piece of paper and a pen to help somebody with aphasia access different language ways, then you're not prepared to have a conversation with them. If I go to the doctor with my mom, who unfortunately suffered a stroke and ironically has aphasia, then we can't have a conversation with the doctor without him looking at me and saying, how's she doing? Which we heard that this morning. Because I didn't prepare for that appointment. I didn't prep with questions that she might want to ask. So a lot of this stuff is going to be about making sure that we're prepared. Must have been a Girl Scout, because I got the whole preparedness thing. And then we have to find out, where are the communication barriers? What is breaking down? The best way I ask this question is I ask the family member to tell me the last time they got so frustrated they felt like they were going to pull their hair out. When was the last time you were embarrassed, or you were scared, or you were frustrated beyond belief? And describe that situation to me. It's great fodder for us for being able to replay that and give you the tools you need to do better at it, but also it tells you what training needs are available, what support systems are going to be available as well. And then knowing that you can't do this once in a while, you have to do it throughout the continuum. This is something that I use constantly, which is just, what's a challenge a person's having? What's some compensatory things we can do? And then what are some things that we can do to, in the area of PPA, hold back the moving train? So this was actually a client who said, yeah, I understand all this, but my husband just came out and put shaving cream on his toothbrush. So what are you going to do about that? And so we talked about the breakdown of executive functioning and then realized that really it was a sequencing problem. And so pictures taped on the wall works. And in the next breakout session, I'm doing one just on tools and techniques, and we'll cover lots of these, including some adaptive. But I'd like to really empower you all to know that helping somebody with communication really just takes putting on a cape and putting that superpower on. And my colleague out in California, I'm in California. I said out in California like I wasn't in, I'm in California, in the same time zone. Roberta Ellman, who is in the Aphasia Center of California, came up with an acronym that I really like to use. And I think that it's a guide for, or a foundation for, to make sure we're doing the right thing for people with aphasia and their families. And it's just 4 simple things: connecting people, providing any tools or assessment or assistive technology that might be able to assist them, making sure we're training partners, and then providing education and resources. All right, the first is connecting. And there have been so many ways. Right here today, you're connecting by sitting together and meeting people at lunch and learning about what they're going through. But there's Facebook groups. There is support groups through that are specific for aphasia, both on Facebook and on websites that I have listed here. And this is in your handout too. There's local support groups, but I would encourage you not just to look at programs that support people with AFTD, but also look for aphasia support groups. Look for PPA-specific groups, and then find connections in that way. Look for aphasia centers. When I started the Triangle Aphasia Project 16 years ago, there were 13 centers, and we started a program called Aphasia Access, where we're just trying to get providers going. There's now almost, there's over 50 aphasia centers across the country. So there's more people doing it. The other place is to look at your local universities. Speech pathology graduate students need clinical practicum and experience. Contact them and see if they can, they're the only ones who aren't bound by insurance, so you could be seeing somebody in those clinics for a very long time. Also look for some creative day programming. Yes, we all know what adult daycare and options like that are, but there's other meetup groups. And if you can find somebody, a support to go with that person, then they can have a lot more engagement. The A is for augmentative and alternative communication. And if I can tell you to put away the idea that there's some fancy equipment that's going to solve this problem. There's not, but there's a lot of real life tools that we all use every day that could help that. A lot of people start with a little notebook or a little brag book and put their information in there. I have aphasia cards, ID bracelets that say I have aphasia. Handing somebody. I have something called a visor card, because many of our folks with PPA may be in a car with either another driver or be driving themselves, and we've had a couple brought down to the police station because they thought something was wrong with them cognitively, and it hadn't been. It was really just language. So we have a visor card that explains to the police anything that you can do to help tell that person's story. And speaking of story, I think it's really essential that people have an opportunity to tell their story. And you can do that with both augmentative systems on your phone and in little notebooks, and then any type of environmental modifications, which I'll go into more in the next breakout. Some simple things that many cities have something called assistive technology centers. They have all types of tools that will be able to help you. I utilize this big button phone for my mom when she had her stroke because she wanted to call us, but was not able to, I'm wrapping up, was not able to do that on her own. So we're giving her just the amount of level of support that she needs so that she can maintain her independence. And then some of these other apps like Photo 365, which will allow someone to take a picture of what they're doing every single day and have a little comment. So then when somebody says, "What did you do yesterday?" they don't have to look at their spouse or their family member, their partner, and say, what did I do yesterday? Telling their story can be done on timelines, photo books. I remember Lori said this morning about how many times she utilized the pictures on her phone and just went over and over them. I like to say this is the time when you go through those pictures and tell stories and write things on the back so you can maintain that storytelling ability. P is partner training, and the big question is who should be trained? Everybody that interacts with the person with aphasia. That means children, grandchildren, friends. The more people that can be trained. When should they be trained? Often. And then how do you know what needs to be trained? You ask. You ask what is breaking down. How can you train? Well, you can train via interactions, real conversations with speech pathologists. Ask your speech pathologist to set up a training where you all can come. Aphasia centers typically do that all the time. We do ones where we get the whole family together and friends. There's so many social media opportunities too. Get a Facebook page and call it, Joni's Facebook page. We did it on care pages after my mom had her stroke, and what I would do is I'd upload suggestions about aphasia right onto that care page, and it would send it out so that everybody knew how to communicate with her. And one of the really quick things is that people were sending her cards and talking about these people in her neighborhood up in Pennsylvania. Well, she was living in North Carolina. She couldn't read their writing and couldn't understand what they were saying. So I put on her care pages, "My mom loves receiving your cards, but do me a favor and type them. Write them a little bigger, and also send a picture along so that it made my mom feel connected and she could continue." Also, keep a live notebook at home where you can put some of that information. And finally, education. Education is key. This conference is key. What an honor to be here today to do this. There's a lot of neighborhoods that are being involved in dementia capable. We have dementia capable Cary in North Carolina. I heard from Lori this morning about Purple Table program, which is a really cool idea. Give Care is a program where a speech pathologist whose mother has aphasia started a program. I guess it's similar to Tinder. I'm beyond Tinder age, but apparently you swipe and no. You find somebody who matches you in terms of what your needs are, and you find a communicative partner that way to support you along the way. But I would actively get involved in those kinds of programs. And thank you so much. The dog does not like applause. We figured that out. You're fine.
Does everybody need to get up and stretch for a sec, or should we just keep going? So, over the past 2.5 years since Tracey's diagnosis, I've learned a few lessons, and I'd like to share a few of them with you. Many of you are farther along on this journey than we are, and I hope that we will have a chance to hear your wisdom along the way as time goes on. First, I'd like to give you some background. Every marriage has its assigned roles, and I managed our life and our finances and our home, and Tracey managed a complex organization. I'm having trouble seeing my iPad here, I'm sorry. There, I think that I can do it here. So Tracey managed a complex organization and a big staff. Her job was to be the extrovert in our family, the advocate, the connection maker, both at work and at home, and my job was to facilitate that. So she invited the entire world to dinner, and I cooked for them. I hired the contractors and the handymen and the house sitters, and she held their feet to the fire. And she kept in touch with everyone she ever met, far and wide, and I made the travel arrangements to get us there. And then life changed. And after months of tests, and after ruling out this and screening for that, and you have a gene for Alzheimer's, but this is not Alzheimer's, yay. And then, oh, we don't know what it is, but it's not Alzheimer's, yay. And then finally this, Tracey, you have a disease you've never heard of. There's no treatment, there's no cure. You're gonna have trouble speaking, and eventually you will become mute. And that thing we all hear, go home and get your affairs in order. So get this, Tracey the communicator is going to become mute, and Emily the shy one is going to have to step up and become the advocate and the social director. And my first thought, which still comes up on a regular basis, was we are totally screwed. And so our journey began. We cycled through the Kubler-Ross stages of grief, denial, anger, bargaining, depression, acceptance, kind of like a washing machine over and over again. And mine got stuck on the anger cycle. I was furious, and sometimes I still am. So lesson number 1, anger, fear, and grief are all part of coming to terms with this disease and the new life that it requires of us. And it's important to acknowledge those feelings, to accept that they are real and they're valid and they're okay. This disease stinks. And it's okay to admit it, and it's okay to admit that you're scared, that you're sad, that you're angry. Say it out loud, say it early, say it often. I don't know about you, but when I said for better or worse, I was not imagining becoming a parent to my spouse before I turned 60. But here we are 20 years later, and our relationship is changing. Those rules and those habits of years of marriage are all in play. And so this is lesson number 2. Over time, more and more of daily life is going to fall on the care partner in your relationship, and neither one of you is going to like it. So try to have the hard discussions and make the difficult decisions now. Don't just talk about how you want to die, talk about how you want to live. Because as the doctor said, get your affairs in order. And then once you've done that, turn your attention to living with FTD and primary progressive aphasia. There's a whole lot of information out there about dying with it. But Tracey and I have decided that we're going to view this and manage it as a chronic disease for as long as possible until we can't. A chronic disease as something to be lived with and adapted to. We all know there's no cure for FTD, but there can be life, liberty, the pursuit of happiness in the midst of it. We're not victims. We are families affected by a disease. Some days are better than others. Some are really good, just like old times, and some are really bad. And our goal is to have more good days than bad ones. Tracey's going to talk a little bit about some of the lifestyle changes that she's made with diet and exercise and mindfulness and stress reduction. And I will tell you that since she's made some of those changes, she's been on the whole a whole lot better. Her thinking is better organized. Her attitude is much improved. She's been working hard to make the good days better, and that's her job. But I'm going to talk about what I do on the bad days, because mitigating them is my job, and getting through each day is a family affair. So for lesson number 3, I want to talk about 3 things that I think are important in understanding about FTD with primary progressive aphasia, and they are anxiety, avoidance, and routine. Anxiety, avoidance, and routine. I think anxiety is the most pervasive undercurrent of dementia, and it's probably the biggest obstacle we have towards speaking and communicating clearly. A person with primary progressive aphasia has enough trouble getting words out, and if she gets anxious, it's even harder. And when Tracey is well rested and calm, it seems easier for her to speak. And if something doesn't go right, and she starts to worry and then obsess about it, and so in addition to driving me crazy, she can't find the ordinary words or get the words out at all. And if the day is really bad, she has what I call the brain explosion, where she cognitively just goes into a fetal position and has a meltdown. And I believe that my job is to run interference so that we don't get into those situations that make Tracey more anxious than she already is. And so that's what I mean by avoidance. Avoid the situations that cause anxiety and confusion. And these are different for everyone, but think loud restaurants, big crowds, places with lots of stimulation, like a sports bar with 7 screens and 100 loud cheering sports fans screaming. Think about 3D movies, busy airports, and try to avoid them. And if you can't avoid them, have a plan for how you're going to get through them. So find the table in the corner where you can't see those screens. Find the back of the coffee shop in that darker part of the airport, and stay there until you just have enough time to walk out of there and to your gate and right onto the plane. Better yet, if you can afford it, a pass to an airline club is a lovely thing. Sometimes this means that I have to be the bummer in the family and say, no, we're not going to go to that rock concert with the light show tonight, even though everybody else is raving about it. If you do something and it doesn't work, don't try to do the same thing again. If every year for the past 20 years you went to the amusement park and you know it like the back of your hand, but this time his brain exploded, don't just put it down to, well, that was today. Put it down to, okay, that didn't work, and it's not going to work. Don't try to do it again. Each time something you thought was going to work doesn't, you need to take that as a sign that the disease is moving on and you should move on too. You used to do that, but you don't do it anymore. So what do you do? And this is where I come to routine. And you've been hearing this from everybody all day. Routine, routine, routine. But it's totally true. Whether you're at the beginning of this journey or well on the way, routine makes your day and your life a little better. I'm not a routine-loving person. I like my day to just go as it goes, and whatever comes up is cool. But FTD demands routine. Knowing what's going to happen and that then having it happen helps you avoid those times where anxiety just takes over. You figure out a schedule, and then you work to try to stick to it. This doesn't mean you have to do the same thing every day, but you kind of have to do the same sort of thing every day. So we start out by planning our day and planning what's going to happen. And we try not to deviate from that plan. Or better yet, we plan the whole week. And every day, make room for exercise, for social interaction, and for downtime. Tracey uses a digital calendar and an Apple Watch. And each day, it shows what time is the gym class, what time is the pickleball game, what time is the yoga class, and so she can choose which one of those she wants to do. And sometimes she has days when decision making is hard, and so she asks me to choose the activity for her. The day and the ability to recall words and speak in sentences goes markedly better if she exercises and eats healthy food. And when the routine falls apart, so does cognition and language. So create a routine and use whatever technology works for you, whether it's paper, digital, Post-it notes on the fridge, whatever works for you, and then try very hard to stick to it. And one last lesson, number 4, don't try to do it alone. Ask for help. Get professional help. Join a support group if there's one near you, or one of the online groups if there isn't. Even though each of us is in a unique situation, there's still so much we can learn from each other about what works and what doesn't. And take advantage of this community, the AFTD community, which for us has been a lifesaver, and use it to help craft the best life you can for as long as you can.
I like that dog. So how many of you have heard me speak or heard me last year at this conference? Okay, that's helpful to know. So in November 2016, I was diagnosed with FTD PPA. I can't remember what kind I have, so please don't ask that question, because as I listen to all of the typologies, I go, yes, and then I hear the next one, I go, that must be it, and then I hear the next one and think that must be it. So, you know, as somebody living with it, I almost think all of these typologies are kind of confusing, because it all feels like I have a hard time talking, I have a hard time thinking, and I sometimes have a hard time moving. So you go figure. But I've been thinking about it, and I think I've gone through 4 distinct phases. And the first phase was for at least a year and maybe longer. I knew there was something wrong, but I didn't know what it was. And it's all that stuff you hear about of, was I confused? Was I burned out? Was I depressed? Was I overly anxious? Was it postmenopausal midlife crisis? All of that stuff. But I kept saying, no, there's something really wrong. And then, so the first phase was not knowing. The second phase was getting that diagnosis. And it really was the most awful day of my life. I got it pretty quickly. It took 6 months. I'm very well connected in the city I live in, so I was able to get to see the best doctors and the best systems and get the tests pretty darn quickly. But it did take 6 months of testing. And the results came on Election Day, 2016. You can sort that out for yourself, what that means. But it was a pretty lousy day all around for me. And so, you know, we did go into this season of relief that I knew there was something wrong with me and why, and grief that everything was falling apart, and escape. I mean, I just wanted to run away from it all. And also a season of trying to put things in order and manage a transition. But then I went through this next phase of accepting it as a terminal disease. And I think this is important to say. I'm kind of done with that. During this acceptance phase, I said, well, okay, I'm going to find meaning and I'm going to find what I'm going to do with my life, but I'm going to die. That average life thing that we hear about of 7 to 10 years after diagnosis, you're going to be dead. I mean, you get that when you're 60, I think I was 62 years old, so I started counting down. And then one day, my oldest and dearest friend in the world, who happens to be a doctor, said to me, Tracey, you don't have to die with this. What do you mean? I am going to die with this. He said, no. He said, you can manage this as a chronic condition. And he said, you can make some changes that will help you manage your disease, possibly slow it down, and who knows, maybe reverse it. Okay, now I'm not a scientist and I'm not a doctor, so I'm not telling you that I am reversing my disease in any way, shape, or form. What I am telling you is that my phone keeps going away. But so here's what I want to tell you is that I really believe that denial isn't useful. Honesty is really important. An early diagnosis will let you get a handle on the whole situation and create a high quality of life for you. And transparency will make it easier for everybody involved. So speaking of transparency, today is a hard day for me. This conference is probably hard for a lot of us who are living with FTD because it throws us out of our rhythm into a big crowd in a foreign city, in a hotel. We're not eating right, probably. We're not exercising the way we ought to be doing, and there are a whole lot of people around. So, you know, it's important to kind of name when you're having a hard time because you can get in this place of denial that makes it more difficult to take care of yourselves. As Emily has said, like most people with FTD, we live with this high level of anxiety. And it's, don't worry about it, it's the anxiety that I'm not going to recognize somebody I know. I'm not going to be able to find the right words. I'm going to get lost. I'm going to get confused, or I'm going to act inappropriately. Even those of us who don't have the behavioral type of FTD struggle with behavior. And I think a lot of that comes from the anxiety. And so managing anxiety is really important. And one of the ways, I manage it in a bunch of different ways. One is meditation. I'm really working hard that when I get in an anxious place, to try to meditate, to try to breathe, to try to calm myself down, even if it means stepping away. I've curtailed so much of my activity level and my conversations so that I only have a few conversations a day because I have learned that I have a quota around language. And so I try to manage that. Thanks to speech therapists, I've learned how to do descriptive workarounds for when I can't find language. My very favorite word in the whole English language right now is thing. You know that thing, and then I describe it. And when I'm with Emily alone, I don't even worry if I don't find the word. I just keep going, and sometimes it comes out pretty funny. If I'm wanting the toaster and I ask for the vacuum cleaner, or I'm talking about the cat and suddenly she's become an elephant. And that's just the truth of it. I don't do a lot of memory training. I probably should. It's really hard to do memory training alone, and I haven't found a group of people with early stage to do it with. But I still read and write a lot, and I'm still preaching and teaching around the country. And it's getting a lot harder, and I can only do it for shorter periods of time without getting frustrated or distracted. But what I've decided is, when that happens, to just stop and say, so I can only read for 20 minutes now. That's okay. With the, when writing, I really rely on Google Dictionary and spell check and thesaurus. With the help of a physical therapist, I'm learning, and I've learned how to address some of my mobility issues, and I'm working really hard to prevent falling. I am exercising regularly. I try to do it daily, and I'm doing a lot of stretching and swimming and aerobic exercise, and I've learned something called functional training, which is really exercise for people over 65. And doing it in a group is great. The problem is it's organizing it. And if you're a care partner, I think that's something you can really help us do, is organize that routine. Another big piece of what I'm doing is relying heavily on technology. And I think that's going to be a big shift in managing PPA as we go forward for our generation, who is not necessarily digital natives, but we've been using it for a long time. My Apple Watch, what I'll say is, hey Google, will you remind me to write a thank you note to AFTD? And it's going to appear on my iPhone so that I don't try to remember stuff anymore. I find one of the things that we do when we have PPA is we become a little bit obsessive because we're so afraid we're going to forget stuff. We do it over and over again and impose it on other people. So one of the things that I do is I tell people up front that I'm going to have to be dealing with, that I have a brain problem and that I tend to have trouble talking, especially if I get anxious, and that I might repeat myself. So please bear with me. And if I shout at you, it's not because I'm shouting, but it's because I'm losing language and I'm just trying to get it out of me. The last thing that I want to talk about is I am exploring an alternative medical approach that some of you have probably read about, and it's the Brandenson Protocol. I am not saying that it will reverse our FTD. There haven't been clinical trials enough to demonstrate it to be true. But with a really dear friend of mine who is a doctor out here and working on alternative approaches to living with dementia, not curing it, but living with it. I am working with him because I trust him profoundly. I have completely changed my diet to trying to be good about carbs and really eliminating gluten in an effort to reduce inflammation. I have been doing intermittent fasting and regular exercise and daily meditation, sleep hygiene, which means kind of trying to make sure I get really good sleep. I'm resting when I'm tired. I live in the present, trying not to worry about what I did in the past and what the future holds. I am taking a pretty long list of doctor-prescribed supplements and vitamins. I have eliminated the mercury in my mouth and gotten rid of all of my silver fillings. I've had some doctor-supervised chemical detox. And honest to God, I do think it's making a difference. For me, I'm not saying it's going to make a difference for anybody else, but it is making a difference for me. And I believe in my heart of hearts that FTD, like other forms of dementia, is a combination of genetics and environment and lifestyle. And we can't change the genetics until medical science comes to terms with that. And we can't change individually the environmental stuff. We can as a society, but each of us can make a decision to try to come to terms with our own lifestyle issues. So I've made that decision for myself because I want to live as long as I can live with this disease before it ends my life. So that's what I want to say, and thank you very much.
Any other questions
this in the middle. One of the problems that my sister is having is to go brush her teeth, the caregivers at the nursing home will put the toothpaste on, and instead of brushing her teeth, she's chewing the toothbrush. So I can see somebody who had a drop-dead gorgeous smile. I can see the buildup, and she gets her teeth cleaned 4 times a year. But any ideas of how to help her actually brush her teeth and not? So that was one thing. Because she's in a nursing home and she's on Medicare, Medi-Cal, what are speech therapy or physical therapy or things like that are available to somebody who's on a Medi health plan in a nursing home? And then associated with that, how to get the nursing home to be able to get her to be on a Mediterranean diet. For God's sake, we're a Mediterranean heritage in my family, and I go to the nursing home to feed her, and I'm like, Jesus Christ, there's like 3/4 of the plate and the dessert are carbs. This is ridiculous. How come she doesn't get any salad?
Yeah.
And she, I think, it started this disease process in 2001, roughly. She wasn't finally diagnosed until 2014. And I don't know where she is in the disease process. She's starting to show signs of Parkinsonism as of a year ago. What other available resources are there for somebody in that situation?
Do you want to begin?
Yeah, I'm chomping at the bit here because my mother is also in a skilled nursing facility. She had broke her hip and is in there. And I have to tell you, talk about changing society. We put so much emphasis on what kids eat in school, but the crap that is in the nursing home diets is disgusting. And I don't think there's anything other than what I mean, when you said, could she get a salad? My mother gets a salad that has 4 pieces of iceberg lettuce, 2 giant tomatoes, and a 1.5 cups of dressing. So I'm not sure, how we can do that. I bring her yogurt, I bring her fruit, I bring her things, and the hardest part is because of her frontal brain injury, which is very similar. Her executive functioning is off. She tends to want carbs, and if a food is placed in front of her, she will eat it. So that's a lot of it is controlling some of that. I'm going to skip to the first question, which, and then the other thing is to go to the skilled nursing advisory council meetings. They have every month, and just keep sharing that, see if you can get a task force of other people involved in that. The very first one you mentioned is really challenging because you have to find out where the breakdown is occurring with the teeth brushing thing, or any behavior. That could be for brushing your hair, it could be any for personal care. One of the things that I find really exciting is what's happening in the area of neuroplasticity. And it's not just about young brains, it's about old brains, and it's about not just learning new skills, but being able to kind of hold back a moving train. And one of the things that is very recent is mirror neurons. And what they're showing is that if you even hear somebody doing something next to you, like why do you think you smile when you take a picture of somebody? It's not of you, unless you have the camera backwards, which I've done. But or if you're feeding a child, you open your mouth, like, no thanks, no peas for me. So when you think about that, one of the things you could do is do a little video. I got my mom a very inexpensive iPad because it breaks and it gets taken at the nursing home, but an older one, see if anyone's got one they're not using, and put videos of her doing that, or you brushing your teeth, and put it as she's watching it, and the mirror neurons will kick in, and she will be able to model that. And then that middle question really about Medicare and stuff it's very sad, but I kind of have advocated a lot in the nursing home for groups, and to see if they could provide group programming under either the nursing restorative care type programs, maintenance care. They are not always covered by Medicare, but they'll do it for quality of life.
Parkinsonism about a year ago, and so they put her in a jerry chair, and then she gained 11 pounds in a month.
Yeah.
And then was stable, and then after our mom died, she gained 9 pounds in a month.
Yeah.
So I told her doctor, I'm like, she's gaining weight because I think she's losing muscle mass by being in the chair so much. And he said, well, she doesn't, she refuses to walk. And I'm like, dude, that is bullshit.
Yeah.
My
It's
sister walked 16 hours a day before she ended up in that jerry chair. If she is walked with the caregivers to make sure she won't fall. And then they started using a walker with her so that she wouldn't take down the two caregivers. And her language got better.
Yeah.
And I knew it would.
Exactly.
But I'm sure the biggest pain in the ass in that nursing home, and I really don't care.
I
You-
think we're
you-
probably on fairly equal ground.
You
but
are an advocate.
you're an
You
advocate,
really
and
are.
you have to be a voice for someone who doesn't have theirs.
Here, I'm here to tell you, on the days that I don't exercise and I don't eat well, my brain doesn't work as well. And I'll bet if we're all honest about that with ourselves, that would be the truth.
A question for Dr. DeSoto. Who diagnoses which form of PPA that an individual has? Is it just based off of symptoms, or what is the process? Here.
So that's a great question. So often it is a physician who can help with the diagnosis, and often it is a neurologist. And the diagnosis comes about first from hearing about what's going on, how things have changed over time. And usually that involves the person who's experiencing the symptoms and somebody who knows them well. There are often tests to rule out other causes of language changes, and one of those, importantly, is to get a brain scan, because sometimes there could have been a stroke that nobody realized, or there could be a brain tumor that's slowly growing and causing these symptoms. So there is usually a brain scan that's part of the diagnosis, starting with a structural scan, such as an MRI or a CAT scan, and then sometimes there is also functional imaging, like an FDG PET scan. Sometimes there is a lumbar puncture involved because we can look to see if the Alzheimer proteins are in the spinal fluid. But a big part of it also is having sometimes neuropsychological testing, but often it does require a specialized speech pathologist to really figure out which variant this is. So it's often a whole team that can put together this diagnosis. And sometimes you can't get it on the first round. Sometimes you have to continue some of the testing, see what's changing or not over time to be more sure about it.
Tracey and Emily, these next questions are for you. Tracey, if you could just say again the name of the protocol that you mentioned you were participating in. What is it called?
You want me to do it? So it's a book called The End of Alzheimer's, and the author's name is Bredesen. I think it's Bredeson. He's way out there, but he's not totally wrong. And there's a lot in there that applies to all of us, whether or not we have FTD or primary progressive aphasia. But it's Bredeson's End of Alzheimer's.
And I'm not doing the whole thing, and you can read about it online, you can read the book, but I think the bottom line is what's good for the heart is good for the brain, and that I think it's about not giving up. I know we say it's a terminal disease, and it is a terminal disease, and that allowed me to get my disability pretty quickly through Social Security and the like, but I think living with it as terminal in our head means we give up. And I think that's the part that we who have it, our care partners, and the care community need to begin to shift for us. Is terminal can be a long way off. And so what do you do in the meantime?
This next question is for both of you as well. How can I help my husband accept to be open to talking about his symptoms? He tries to pretend he's normal.
Is that you, Dawn?
You just keep at it, and some days there are some days where arguing it's not going to work. you just keep at it, and you keep, I mean, one of the things, the advantages I have with Tracey is that she's the most self-aware person I ever met. And I was denying it much longer than she was. But there are days when I have to say, wait a minute, this isn't working, you know, pretending that something's not going on here, and we have to stop. And you just keep bringing it up and bringing it up until you keep bringing it up.
I think the other thing is if you were dealing with somebody with diabetes or heart condition or cancer or even an addiction issue, sometimes if the whole family can get together and say, we're all seeing this and we love you and it's nothing to be ashamed of, but we got to come to terms with it because it's really wrecking our family. Mm-hmm. Do you all want to say anything about that?
Well, and I might add to that, for some people with this disease, they do lose that insight into what is happening. So they truly may not notice the same symptoms that you are seeing.
That's my question. And so I don't guess I wrote it too well. He's 87 years old, and he's very traditional in his 87-year-oldness. And for instance, the cards are a wonderful thing. And the button that says, I have AFTD. And he acknowledges it more with me, and we've done a lot of progress just between the two of us. But it makes it very different, puts me in that position again of, you know, telling people, because I want them to know that he's not just, you know, out of it. At the same time, it doesn't, I'm tired of doing it that way, and I don't know how to put this better, but we're very open with each other and in most things, but I just haven't figured out how to, it would make it so much easier if he could use those cards and I could use those cards and we could talk to the world that way. Our family does know, they don't quite completely understand either, so I don't know, is there?
I think you start with your friends. And you try to be really upfront with your friends about this is what's happening. It's not that he's out of it. And that actually might be a relief to him to have some friends who know. I don't think you have to necessarily start out with a total stranger and say, you know, he's out of it. I mean, no, he's not out of it. He's got this disease. But, you know, start with your smaller circle of people, and this is a disease, and you have to be upfront about it. There is this piece of FTD where people often don't know, and they don't remember those situations. Like Tracey will have these colossal meltdowns, and the next day she'll remember that the situation was uncomfortable, but she won't remember that she was in a fetal position on the floor crying because she couldn't decide which pair of shoes to wear. And yet I want as her care partner, I want my family to know that, you know, I have this other life. It's as much for your sanity as his.
I also think that there's a generational issue here. I mean, and I've said this before, I think that dementia in general, whether it's Alzheimer's or FTD or vascular, I liken it to cancer in the 1960s and AIDS in the 1980s. With just, it's a disease that we fear desperately, we don't fully understand, and there's a big element of shame. And until we can break that stereotype by talking about it publicly, which is what conferences like this do, we're not going to get through that. So your husband is 87, and he has 87 years of social... And he's a man. 87 years of being a man in this world and knowing how men are supposed to behave and what they're supposed to say and what they're not supposed to say. And you might not get through that one with him.
And I know this isn't solving that particular question, but it's feeding onto what you just said about the stigma associated with aphasia and the need to be protective and nurturing and all of that as somebody who loves somebody with aphasia. And what I would say is I've been told, you know, why don't you get that rid of by a marketing person? You have this program, Triangle Aphasia Project. Nobody knows what aphasia is. Why don't you just change your name? I'm like, No, because that's the whole point. When I'm done with my trainings, I always tell the families, you know what, do me one favor and just tell one other person what aphasia is. You know, we still have 86.5% of people have never heard of the word. And when they have heard of the word, they think it's like a skin condition. So it's really vital that we keep saying that word over and over. We don't have a national spokesperson. We don't have one person because it's so different among everybody. So just keep sharing the word and advocating. I think that's really key.
It's pretended that it doesn't exist when we all get together.
It's the elephant in the room.
So have a party and
Call it the aphasia party.
With our time left, we have a few questions for Maura, and we'll rapid fire these. Would learning sign language help someone with PPA?
Yeah, that's a really loaded question, especially when someone this morning said that they did do that. Lori said she did learn the 20 signs. We always say learning a new language is like, might as well learn German. I mean, it's still, aphasia is a loss of language. And so to learn a new language is challenging, but use of gestures and stuff like that's really important.
How would you find a speech therapist who knows about PPA specifically and someone to come provide that service in the home?
Yeah, that's a really good question. And I think that there are more and more speech pathologists that are understanding what primary progressive aphasia is and how it is different from aphasia from stroke or brain injury. So the first place you can go to is Aphasia Access, which is a provider network. And I can give you all of these places, but also American Speech Language Hearing Association, which is ASHA, located in Maryland. They have a list of speech pathologists and can identify those who are particularly skilled in an area. So you'd look for adult neurogenics. And the other is to look for, ask your doctor, especially if he's a neurologist that specializes in PPA or FTD, who do you recommend? Because they quickly will not refer to speech pathologists who don't really understand what aphasia is. Don't waste any Medicare appointments with someone who doesn't get it. You got to get the person who gets it.
And then finally, if you can summarize this, what is memory training?
I definitely can't summarize that. I think that when you're thinking, again, I'm a really big neuroplasticity geek. I think that we are learning so much about the brain, and we have, there was an article in 2008 called the 10 salient, basically the 10 neuroplastic principles, so experience-based neuroplastic principles. And in that talked about repetition, saliency, use it or lose it, use it and improve it. Those things are what why people do memory training. Is it's saying, okay, we're all getting a little older, the connections start to go, but there's so much of our brain we don't use. Why don't we make sure that and which is why our neurologist who specializes in PPA always says, get a dog, talk to, do some art, try to use multi areas of the brain. It really has to do with those 10 principles is repetition. And I would really look for that article because I think it really helps understand what it means.
Thank you all
cover more in the breakout.
so much. I'm sorry we are out of time, but find our panelists later on today and ask them more questions. Thank you all for coming.